And then if for whatever reason any of the audio or if you're people streaming on YouTube say that it's cutting out, just let us know. We can fix it. All right, so let's get started. So I appreciate you guys taking the time to talk about this case with me. And I apologize for being a bit late. The previous sessions ran over, and then I also got a little hungry. So what we're going to be doing today is going through the chest pain case, and you have the case, so you have generally everything that happened within the case, but we're going to dive deeper into the history and what everything means. The most important thing about this is not so much to get the right diagnosis. A lot of people got the right diagnosis. That's really, for me, it's not super important. What I care about more is that we know how we got to that diagnosis. So I will be calling on you guys. If your mic doesn't work, you can just comment that it's not working, and I can move on. But try your best to answer as best you can. Okay, so the case goes that we have a 78-year-old female who presented with progressive chest pain and shortness of breath over the last 1 to 2 weeks. She's alert and oriented to herself and to the time, but not to the place of the situation. The daughter's present to help you with some of the history taking. So she's coming in with chest pain and shortness of breath. So Dr. Perez, what do you want to know about that?
Wait, I'm sorry. What was the question?
So
she's coming in with chest pain.
Is the audio not like working well, or?
Okay, it's because you sounded like staticky.
Oh, sorry.
It's okay.
Is it better now?
Yeah.
Okay, so she's complaining of chest pain and shortness of breath. So what do you want to know? Like, what would you ask next in regards to that?
I'll probably ask, like, when did it start, or if there's anything in particular that is causing it to be worse.
Okay, so we know that it started about a week or so ago, and nothing really that she notes that makes it worse other than her cough. She would normally walk around the block daily, but she hasn't really been wanting to, according to the daughter. Good. So Dr. Patel, I told you that she has 2 weeks. 2 weeks ago, she had a sore throat, congestion, and a slight cough. What would that make you concerned about?
I would be concerned about any like residual infection or anything that's still lasting. So it seems like she got better, but the cough is still there, it lingered. So I'd be maybe the infection is still slightly in her system.
Okay. So I missed the last half of that. Sorry.
Oh, I was just saying that it seems that the cough did linger. So even though her overall symptoms improved, I'd be concerned if part of the infection or whatever she had previously is still in her system.
Okay, good. So her symptoms overall improved after the 3 days of her cough lingered, like you said. And then a week ago is when she started to feel weak and started complaining of the chest discomfort. I also mentioned that 6 days ago she was up at night confused and could not sleep because of the cough. Why would I mention that, Dr. Patel?
When I first read that, I kind of was thinking something about pericarditis. Like whenever you're sleeping on your back instead of leaning forward. So maybe it could be some type of friction. And so when she coughs, her pain gets worse.
Okay. And so, yes, definitely. But what about the confusion?
I think that explains kind of her dementia, which is stated like later on.
Okay. So she does have dementia, but her daughter is saying that her dementia, so her confusion is worse than what she had before. So this is on top of her dementia. She feels she appears more confused. So why would I mention that?
I'm not really sure, but I'm thinking that maybe, yeah, I'm not sure, but I think that her symptoms are because they're worsening with the cough. It might be because she's restless and fatigued.
So yeah, it kind of all plays in that same picture. So whenever a patient comes in to the hospital, and especially when they have dementia, if they have something above their baseline of dementia, so like if they we usually are able to tell you the date, who the president is and all that. But now she's having additional confusion where she doesn't really know where she's at. Those are signs of something more serious going on. Either it's very rare for dementia to be that acutely changed. So a lot of times it's because of an infection. It can be because of a stroke, so not enough oxygen to the brain. Really, any acute insult can cause that. So that helps us kind of determine that there's something else really going on, and it's not just her dementia. Okay, perfect. So as she continued to cough, her chest pain worsened. Actually, hold on. Let me read some of the comments. So side effects of her meds could contribute to her confusion. Yeah, so that's definitely a good point. One of the leading reasons why a lot of the patients that I see in the hospital, there's some type of medication problem, especially if like medications are changed, and we'll definitely get to that. Okay, so as she continued to cough, her chest pain worsened. So, Dr. Muncy, is there what would you make of that statement?
So since her coughing is worsening, I would think that she had maybe a respiratory disease or some type of like issue with her lungs.
Okay.
And yeah.
But what about specifically that as she coughs, her chest pain is starting to worsen? What would that tell you? Is there anything that that brings up?
I think it could also bring up issues with her heart, like if there was like a cardiac like disease or something, maybe like hypertension.
Not so much the hypertension, but you mentioned the cardiac disease. So if she were to have something like pericarditis, so the lining of the heart was inflamed, as you start to cough, you're kind of rubbing that against the lungs, and you're going to cause more friction, causing more pain. So that's definitely it. But what else is in the chest that can cause you chest pain when you cough? And people in the comments are helping you out.
Her intercostal muscles are sore.
Yeah, perfect. So, and you guys feel free to look at the comments because people are going to help each other out a lot, and that's okay. So yeah, so when we usually breathe, our rib muscles and our ribs usually don't move a ton. You're not putting a lot of force there, but when you're coughing, you're really exerting that force and trying to bring everything in the lungs up. And so you cause inflammation of the junction between the ribs and the sternum through that like cartilage attachment. And so that causes something called costochondritis. And so a lot of times we do see chest pain because of costochondritis. And so you have to be able to distinguish, is this something that's happening because the patient is exercising and now they are having pain and it gets better with rest, which sounds more like a cardiac issue, or is it that they're coughing and they're aggravating their chest and that's why they're having pain? So it's an important thing to be able to distinguish. But that's really good. Let me see. So the cough was non-productive, and the daughter states they didn't have a thermometer at home, but she felt warm about 2 days ago. So Dr. Chowdhury, what do you make of that her cough was non-productive and she felt warm? Dr. Chowdhury here? It's okay. Dr. Mushtaq, and I apologize if I mispronounce your name. What do you make of that her cough is non-productive and she felt warm?
Well, for the fact that she felt warm, there's definitely like an infection that her body is trying to fight. Her cough being non-productive was one of the main reasons that I kind of, me and my group kind of shied away from a pneumonia diagnosis, because originally we did think that, but with pneumonia, pneumonia is kind of known for like the wet cough and like mucus. So we weren't really sure, and because of that, we chose pulmonary embolism as the diagnosis.
Good. Okay. So a few things there. So you're definitely right. Pneumonia typically causes a wet cough, but in patients with that are elderly, a lot of times they won't have a wet cough, so they can have a non-productive cough as well. Now, what about the feeling warm? Does that automatically mean she has a fever?
Not necessarily. It could also mean that she's just sweating or exerting herself, I think.
Yeah. A lot of times patients will come in and say, I felt warm at home, and we don't really have kind of a way to validate that because they don't have a thermometer. And so initially, like when I first started as a resident, I was like, oh yeah, it's probably not a true fever because they don't have a fever here. But you should always take the patient's word for it, even if they feel warm, because an infection can potentially kill you. And so you want to be able to rule that out. And so you should always, for the future, like keep, take the patient's word for it, because it's always easier to rule it out and then go into something else than to miss an infection. But yeah, I definitely agree that with what you said. So, okay, so Dr. Joy Chang. So tell me a little bit about her chest pain. So we said that it's located in the right lower chest, parasternally, and radiates to the right arm. So what does that tell you about her pain?
I think that since it's like in her right chest, not her left, it has to do something besides her heart.
Okay.
And like looking at the x-ray, there is like stuff showing up in the right area too.
Okay. Definitely. Heart attack so a heart attack typically, so like the typical symptoms would be kind of like that pressure type feeling like something sitting on your chest. It can radiate to the shoulder. But like I had mentioned in the videos, you should always have a high suspicion for a heart attack because people will present differently. especially elderly patients and especially elderly women. And so I definitely agree, though, that there's something going on that right side. What about when I say that it radiates to the right arm? Does that mean anything to you? Does it bring any bells about anything? This is a hard question, so it's okay if you don't know.
I don't know exactly, but maybe like some of her pain could be like affecting like her muscle move, like her muscle or like something about that. I'm not sure.
That's okay. Dr. Rohan Shah, you mentioned diaphragm inflammation. So can you explain that?
Yeah, so since it says that her pain is located on the right lower chest and it radiates to the right arm, I was reading that so it could be coming from, her ribs, and that's because her diaphragm is inflamed, so it's kind of pushing up, and that leads to your right arm being affected by this.
Why?
Why?
It's okay if you don't know. It's a really hard question.
I'm not sure about that.
Okay, so your diaphragm is innervated by the cervical nerve C3 to C5, and so those nerves are actually also innervate that right shoulder area, and so it's referred pain. So if you think of males, if they're ever hit in the testicles, it hurts in their belly, right? Because that's where the nerve fibers that innervate the testicles actually come from. So same thing with if you have somebody that gets an abdominal surgery and it's laparoscopic, so they put a bunch of air into the belly so they can actually look inside the belly and do everything with instruments. Well, once they take everything out, you still have a little bit of gas in there. That gas sits under the diaphragm and it can irritate the diaphragm. And so a lot of times you have these patients saying, "Wow, my shoulder really hurts," and it lasts a few days as your body reabsorbs the air. And so it's that referred type pain that, because these come from similar structures embryonically, that you have that referral of pain. So whenever somebody says that their right shoulder hurts and they're having chest pain, think of a diaphragmatic issue as well. But good job. It tells us the pain is not due to ischemia. Okay, it can be a sign of angina. Yeah, so if it's not blatantly positional chest pain, we can rule out pericarditis. Yeah, I don't know if you can blatantly rule out pericarditis. You should keep it in your differential, but you can put it lower in your differential. Okay, so so she describes it as a sharp and stabbing pain worsening with deep breathing. So Dr. Espinosa Ruiz, what does that tell you? Okay. Dr. Vinewin, what does that tell you?
Can you repeat the question, please?
So if she's saying that the pain is sharp and stabbing and it worsens with deep breathing, what would that make you think about?
I would think of pneumonia.
Why is that?
I'm not sure because according to like other like signs and then her labs as well, but
Okay,
I'm not sure why.
Yeah, so looking at like the actual history, when you have inflammation of the line, yeah, perfect. So when you have inflammation of the pleural lining, whenever you take a deep breath or you cough, you're gonna have pain. And so if you had something like pneumonia, you can definitely cause that inflammation, giving you those symptoms. Same thing with pericarditis. You can have pain when you take in deep breaths because that lining is now rubbing against the inflamed pericardium. Yeah, so perfect. So this morning, her daughter states that her mom appeared more confused and she refused to eat. So Dr. Ismail, why would I mention that?
So what I think is like going along with the diagnosis of pneumonia, is that with pneumonia, some of these symptoms are being lethargic and not wanting to eat, which also entails with her fever, so her not feeling well.
Mm-hmm. It's perfect. So when you don't feel well in general, a lot of times you don't want to eat. So you can think back of like whenever you're really sick, like you don't have that drive to eat, you don't have that appetite. But there is a specific reason why I'm talking about why she's appearing more confused and she's refusing to eat. And do you have an idea why?
I was thinking about like the medication that she's been taking. So like as a question, like I would have asked her daughter is how long she's been on her medication and if there's been any recent changes.
Perfect.
Because sorry, yeah.
No, go for it.
So when I was like looking through like the medication that she was taking, I can't remember which one exactly, but I believe one of them had a side effect of causing almost like flu-like symptoms and dizziness and nausea. So I would think I would attribute to her overall confusion.
Potentially, yeah. So the reason why I mentioned more confusion and that she refused to eat because it does have dementia, and so it's a change in her baseline. So whenever you see a patient, especially patients that have dementia, you have to be able to distinguish: is this something that's normal for them, or is this a change from their baseline? And so for her, this is definitely a change because she would usually eat normally, and she is able to have some sort of mentation. So that's why it's really important to kind of get that history and get collaboration from the daughter. So perfect. And so I say that she denies chills, nausea, vomiting, abdominal pain, hemoptysis, loss of consciousness, palpitations, and anosmia. So Dr. Ruiz, what in there do you think is most important? Dr. Ruiz? Oh, okay. Dr. Jaramillo, what do you think in her review of systems is most important?
So I would probably say maybe the abdominal pain because it can help rule out some other possible causes of it.
Yep, sure. What about somebody had mentioned in the comments anosmia? So why would I mention anosmia?
I'm not too sure about that.
So anosmia is the inability to smell, right? So what's going on right now that everybody's concerned about? That is the reason why we're doing this virtually.
Coronavirus.
Yes, perfect. So a lot of you, if you guys are scribing right now or in the hospitals, be on the lookout for anosmia because all the patients that I've seen that have anosmia had COVID. So so be aware of it, protect yourself. That's why I put it in here. Anything else in her ROS you think is important to know?
I put rapid breathing, she had said, so that's also another symptom she's experiencing. And then shortness of breath, but
what about hemoptysis? What about hemoptysis? Let's go to Sarah, Dr. Sarah Al-Shamari.
So hemoptysis, denying that means, for me at least, that it wasn't consistent with a pulmonary embolism because, hemoptysis is coughing up blood.
Mm-hmm.
So
do you always get hemoptysis with pulmonary embolism?
No, not always, but it's typical, I think, from what I read.
I don't think I've ever seen hemoptysis with a pulmonary embolism. I know it's in the anything like that, for sure. It must be my experience, but I think most of the time for pulmonary embolism, the symptoms I usually see is shortness of breath and they're tachycardic. Those are like the most classic signs that I've seen. But but yeah, it can definitely cause hemoptysis, and that's a really, really good thought. What else are you not worried about? What else would you be worried about if they had hemoptysis?
If they had hemoptysis, I would also possibly be worried about pneumonia, but she did state she had a non-productive cough, but she's also old. Because
Okay.
you would have to do like a sputum test, I think is what it was called, for pneumonia.
You don't have to, but if something is really dangerous and nobody wants to get that can you to cough up. And it's a little bit of tell me what
Most
I'm
likely
hard, so.
TB or tuberculosis.
Tuberculosis is one of them, and definitely we don't want to get tuberculosis. So whenever somebody comes in with a cough, and you should always ask if there's blood in it because you want to protect yourself from TB. Something else in smokers specifically. That can
Smokers,
cause coughing up blood.
bronchitis.
Bronchitis wouldn't typically cause you to cough up blood. So cancer basically is what I'm getting at. So
Okay.
With cancer, yeah. So with cancer, you're coughing up blood because there's a disruption of the tissue, right? So with cancer, you have abnormal cells invading that space, and so you're disrupting the vessels, and you're bleeding into the area, causing irritation, causing you to cough up that blood. And so, so because she doesn't really have a hemoptysis, you can't rule out cancer, but it helps to bring it a little bit lower in your differential. So perfect, good job. So okay, so I said that the patient lives at home with her daughter, son-in-law, and 2 grandchildren, and that the son-in-law is working and he has to go to his office to work. So Dr. Nikki Watson, why did I mention that?
I think that, so it looks like she's the only caretaker of the 2 grandchildren, so she's usually independent, and her ADLs are usually good, but both her daughter and son-in-law work, so she's the main caretaker for the children, whether that means cleaning or, like picking them up or something like that, depending on what those kind of activities are and how old they are.
Perfect. So that's actually a really good point because she was independent of her ADL, so that kind of contributes to us saying that this is very different from her. But if she's by herself a lot and she's taking medications, is it possible that she might have taken too much medications?
Yeah, I think especially with her dementia, like that might contribute to maybe forgetting that she took them in the morning or forgetting which dose that she took of what, or maybe like getting the doses mixed up of each drug that she's taking. That could definitely.
Yeah, exactly. So looking at her medications, is there any medication that would potentially cause her to have confusion if she took extra doses of it? And this is a hard question. So if you don't know, it's okay.
I would say maybe aspirin if she took too much of it. And possibly metformin, but I'm not super positive on what those side effects are.
Metformin. I'd have to actually look that up because I'm thinking metformin. If you do take too much, you can maybe get like a lactic acidosis. But Dr. Shaw mentioned glipizide, and so glipizide actually lowers your blood sugar. And so if you take too much of it, then your blood sugar can drop really low, and you can become confused, like she is. But we know from later in the case that her blood sugar is high, so most likely not.
Okay.
Perfect. Good job. Okay, so Dr. Mia, Atikul Mia, can you interpret her vitals? So her blood pressure is 158/93, her heart rate's 110, her respiratory rate's 24, her temperature is 100.5, and she's satting 93% on room air.
So it looks like she's on the unstable side of her heart rate, like it's higher than normal.
Okay.
And her respiratory rate is also higher than normal. So
okay.
I feel like something on her body is causing stress on her vitals. So
okay.
people mentioned pneumonia, so it might be an infection in the lungs that are causing her body to like kind of like overexert herself to some degree.
Okay, so is there a term for a severe type of inflammatory state that her vitals are kind of showing us?
I'm not really sure.
It's okay. Let's if anybody else know. So yeah, Dr. Spring, Gabby Spring, tell us a little bit about what you're saying.
Yeah, so I said that maybe she has sepsis because usually that is so an over-inflammatory response kind of throws everything out of balance. So it says that she does have a change in mental status. She has a fever. Her respiratory rate is up, and so those are usually common signs of sepsis.
Yeah. So exactly, perfect. So so the criteria for SIRS, which is systemic inflammatory response syndrome, is to have an elevated heart rate, so a heart rate above 90, a respiratory rate above 20, temp above 100.4, and a white blood cell count. I forget the value of the white blood cell count, but she hits all 4 criteria. And if she has a potential source of infection, then she would be categorized as sepsis. So if you have somebody with these vitals, but you don't know where, what's the cause of her potential sepsis, it's called SIRS. But yes, perfect. That's exactly correct. So she has some type of inflammatory syndrome going on. So Dr. Hussein, what in her physical exam is most worrisome to you, or what stands out to you?
So I feel like the fact that she's tachycardic is a big red flag.
Okay. What are you thinking of if she's tachycardic?
It's just that her heart rate's like off. So like even her high BP, that supports that her tachycardia, and I'm not really too sure on how to interpret that.
It's okay. Is there any diseases that can cause potentially just tachycardia? We had mentioned it a little bit earlier.
Is it pericarditis?
I think, yeah, pericarditis can potentially cause a little bit of tachycardia. Dr. Yerger is helping you out.
Oh, pulmonary embolism.
Yeah, so a PE can cause tachycardia. Really, anything that, like you said, anything that's stressing the body can cause it. If she had an infection, that can definitely cause it as well. So, good job. Now, since we asked Dr. Yerger, since Dr. Yerger helped out, what else in her physical exam stands out to you?
I think her increased work of breathing, as well as the mild crackled noises that were noted, are worrisome.
Okay. What are you thinking about with those symptoms or those findings?
I'm thinking pneumonia. I'm thinking the crackling noise is due to rubbing somewhere in the lungs, and also, I don't know if I was looking at the X-ray that you provided on the case sheet, and I noticed in the right lower lobe of the right lung that there was some kind of inflammation, it looked like, or maybe fluid. I don't exactly know how to read an X-ray, but that led me to believe that the pain that she was having was caused by that seen in the X-ray due to the crackled noises and the difficulty breathing. I think that would be why that's happening.
Okay, perfect. Yeah, so the crackles themselves tell us that there's something going on in the lungs. A lot of times with the crackles, it's not so much the rubbing of the pleura, because that would cause more of kind of like a friction rub type sound, like a scratchy type sound, but the crackles themselves are usually because of some fluid in the lungs. So Dr. Fatima mentioned a low O2 sat. So Dr. Fatima, do you want to explain that a bit more?
Yeah, so what I got from the low O2 sat percentage was that there's reduced oxygen flow, so the patient has hypoxia, and that again confirms that it's likely a pulmonary diagnosis. Like
Okay. If your heart wasn't able to pump, would you have hypoxia as well?
Yeah.
Okay. Yes. So it can still be outside of the lungs, but usually if it's a heart problem and you're hypoxic, you're probably coding. So most likely you're not gonna. She wouldn't be able to be as responsive as she was if that was the case. But yes, you are right that it's likely something involved with the lungs. So good job. Okay, so we'll stay with you. Anything else in the history, in the physical exam that you're worried about that pops out to you?
She's still appearing pretty lethargic. So
Okay.
still pretty disoriented.
Good job. And then what about the tachymucous membranes? What does that mean?
I guess it could kind of be a sign that she's dehydrated.
Good job. Yeah. So so usually when the mucous membranes are a little dry and tacky, it's because of dehydration. And yeah. So Dr. Saya was also saying that potentially the diabetes. So yeah, when we get to the labs, we can definitely talk about that. Good job. So Dr. Cax, anything in the CBC that looks concerning to you?
Yeah, so the white blood count is really elevated. It's at 16.9 thousand. So that was kind of a sign of like inflammation or infection.
Okay. So what are some things that you can think of in going on with her that can potentially cause that white blood cell count being that high?
Probably going around, like as some people were saying, like pneumonia, or even just the actual friction of having coughing and.
Okay. Good. Anything else that you know of that can cause a high white blood cell count?
Cancer.
Cancer can. I think Dr. Shaw was saying all of her medications cause a high white blood cell count. I don't think so. I don't typically see elevated white count with those meds, but Dr. Cax, do you know of any medications that can cause an elevated white blood cell count?
At this moment, no.
It's okay. So Dr. Shaw said steroids. So steroids are something that can definitely cause an elevated white count. And we see that a lot, especially in patients that have a pneumonia. A lot of times with pneumonia, we give steroids because people die from pneumonia, not because of the pneumonia itself, but because of how our body responds to the pneumonia, and it causes an inflammatory response within the lungs called ARDS. And so the way to treat that is to give steroids. And so sometimes when you're trying to treat the pneumonia and then you start giving steroids, you see the white blood cell count go up and you think, oh shoot, did we make the pneumonia worse? But no, it's not the pneumonia, it's the steroids. So that's something that is important to know for the future. So, okay. The basic metabolic panel, Dr. Jane, Sonia Jane, anything in there that sticks out to you?
So the BUN is really high and the CR is also very high, which could be because of her kidney diseases.
Okay. So if we're thinking it's her kidney disease, she does have chronic kidney disease, but what about her value makes us think it's not her CKD?
I don't know about that.
So her baseline creatinine is 1.1. So if we drew her blood at any given time, we're going to see her creatinines around that level. Now it's 1.8. So is that a significant difference in the amount of in her creatinine level?
No, I don't think so.
It is. So so it is above her baseline. So that means that there is some type of kidney injury going on. Does that make sense?
Yeah.
So
Yeah.
Because the creatinine level is up, we know that there's some type of kidney injury going on, and there's an acute kidney process going on. So a lot of times that's because the kidneys aren't properly perfused. So if you don't have enough blood flow to the kidney, it can cause something like AKI. And then people had mentioned her glucose being elevated. So Dr. Megana, with her glucose level, are you concerned about anything? Dr. Marcia, does her glucose mean anything to you? Do you think that that's something we should worry about?
I think, hold on. What's the baseline for glucose? I didn't look that up. Sorry.
So it depends. So normal glucose is going to be anywhere between 120 and 140, but for her, if we look at her, this is a harder question. If we look at her A1C, we know that on average her glucose levels run high. So she's not controlled on her diabetes. So the glucose of 288 is high, but for her it's probably not super high. Because what we are sometimes concerned about is what Dr. Saya is saying is DKA, which is diabetic ketoacidosis. And so in DKA, if your blood sugars go really high, like in the 500s, 600s, your body's not able to break down the glucose, so it starts breaking down things into keto acids, and so you end up becoming more acidic. And so that can cause confusion, but for her levels aren't high enough for us to actually think that. So good job. So some YouTube comments are saying for pericarditis, it would show more enlarged heart in the chest x-ray. Not traditionally, it's only if you have tamponade. And the rest is okay. All right, so perfect. Now, let me see. Dr. Manas, from group 34. What do you make of her troponin?
You can see that's high.
It's high. So how would you interpret that?
That kind of like suggests like heart damage or something.
Okay. So walk me through that. So you're saying that she's having some heart damage. So do you think she has a heart attack?
It's possible that she could be on the verge of having one.
Okay, good. So do you think it's likely?
Suggesting that her past history of having coronary artery disease and that she already had some sort of like stents placed in her heart, it's possible that she could be having one later.
Good. So that's a tricky question because her symptoms don't sound like a heart attack, right? She's not having crushing substernal chest pain that gets better with rest and worse with exercise, all that stuff, right? But she has a pretty relevant history, so you can't discount it completely. So for that level, though, the troponin of 0.07, it's not super high where we have to be like, oh my God, we have to take her to the cath lab. Now, what would you do for that level to see if this is something we need to worry about emergently?
I mean, to see if it's like something you need to really actually relate to the heart, you could possibly do a stress test to see like. You can also do an EKG.
Yeah, so you can do a stress test, but you typically won't do it in this patient if you're not suspecting a cardiac issue. But the EKG is a really, really good point. What would you typically find on EKG? Actually, hold on. Dr. Perez, what would you find on the EKG if she were having a cardiac issue?
Sorry, I was speaking, but you'd probably find because you're looking at the electrical activity, so you'd probably find different types of elevations. Yeah, like the ST segments.
Okay. So perfect. Dr. Tarun. So Dr. Perez was saying that if you had an STA segment elevation, you'd be worried about a heart attack. What else would you potentially see that would make you worried about some type of ischemic process going on?
Sorry, can you repeat the question again?
So if ST segment elevation can cause it can be a sign of a heart attack, but are there any other signs of a heart attack that you can potentially see in on EKG?
Tachycardia.
Tachycardia.
And also like tombstones as well.
Yeah, so the tombstones are the ST elevations. If you have depressions, you can also that can also be a sign of a heart attack, and T wave inversions. The tachycardia that you mentioned, it's more indicative of what process?
That I don't know.
So a pulmonary embolism can show up as just straight tachycardia, and that's what it typically shows up on EKG. Okay, so Dr. Saya, I think you have probably okay. So last time I tried to pull up the chest X-ray, I think my screen went blank. So would you be able to interpret that chest X-ray for me?
So on the right side, her lungs seem kind of cloudy from what I see.
Okay.
And then, like the lower part of her right lung seems weird.
So it looks like a bunch of stuff in there, right?
Mm-hmm.
So when we look at chest X-rays, I'll run through chest X-rays with you in the future, but the easiest way to read a chest X-ray is to look for symmetry. So the right lung is supposed to look like the left lung, except on the left side you have a little bit of your heart pushing into it, but it should overall look symmetrical. So if you're ever not sure, if there's like some cloudiness there, look on the left side. If it's also there, then one, you might be having a bilateral issue, but two, if you're worried about a pneumonia and it looks asymmetrical, then you can be a little bit more certain that something is there. So that's the easiest way to kind of pick something out when you're not really trained on how to do it. But you just have to keep looking at these over and over and over again to kind of get what the normal is. Does that make sense?
Yep, it does make sense, yeah.
Okay. So what do you think is going on with this patient?
I think she has maybe some sort of like viral infection.
Okay, why is that?
Her symptoms line up with it, or it could be pneumonia.
Okay, so with a viral illness, do you think that you'll have the chest X-ray looking the way it does?
I don't know.
So with a viral pneumonia, you can have some findings on chest X-ray, but it looks more hazy everywhere. It doesn't typically look like a consolidation in one area. That consolidation in one area is more kind of like a bacterial infection. So so I agree with you that this is pneumonia.
Okay.
Yeah, so I agree with you. It's a pneumonia, and that consolidation is kind of like almost like pus sitting in that area in a way, right? It's not necessarily pus per se because that's more of an abscess, but you get what I'm saying. So Dr. Jason Fan, were there any other diagnoses that you were thinking of other than pneumonia?
I originally thought some type of pericarditis just because of the deep breathing and how it was the pain was worsening with her deep breathing.
Okay. And why did you think it wasn't pericarditis?
One of the reasons why I don't think in the physical exam we got to hear any friction rub sounds.
Okay.
And
good.
yeah, and then also I think in the X-ray it doesn't seem like the mediastinum is like swollen.
So with the enlarged mediastinum, what would that be indicative of? It's not pericarditis. It's something else.
Oh wait, it would be the aortic dissection. Right? Would that be?
Yes. Yeah.
My bad.
Good. Dr. Emma, I'm sorry, your last name. How do you pronounce your last name, actually?
It's just Budenhagen.
Okay. Sorry. What would you see on EKG for pericarditis?
For pericarditis, I think there would maybe be some ST elevations, like kind of similar to an MI, but in a specific spot of the heart. Would be an MI, but in pericarditis, it would be in all of the leads.
Good. So exactly. So it would be diffuse ST segment elevation. The MI is specifically in a specific territory. So it's one artery that's blocked off that's causing death of that area. The ST segment elevation diffusely is because of the changes in the way the heart is signaling because of the inflammation of the pericardium. So yeah, very, very, very good job. So let me see. Dr. Parnita, was there any other diagnoses that you were thinking of?
No, our group was pretty much, we had decided pneumonia and then possibly pericarditis as a result of the pneumonia, but because there weren't diffuse ST elevations on all of the leads, we pretty much said no to that as well.
Good. Is there any, is there a specific type of pneumonia that you guys were thinking of? I know this is a harder question.
No.
It's okay.
So we were basically saying that because there are like infiltrates on that right side of the lung, it would probably maybe be bacterial, or is it viral or bacterial that has a non-productive cough? I don't remember.
Usually viral will have a non-productive cough, but you can get it for a bacterial infection too. But do you think this is a community-acquired pneumonia or a different type of pneumonia?
I don't know the difference between those. I'm sorry.
It's okay. It's okay. I told you it's a harder question. Dr. Fatima, do you potentially know the difference? Or any other type of pneumonia this could be?
Between which pneumonias?
So a community-acquired, hospital-acquired, and there's an aspiration pneumonia.
Oh, so community acquired, I guess, just from like being around other people who have the pneumonia and you're able to contract it from them.
Yep.
Hospital acquired, like in your hospital stay, if you just contract it then.
Yep.
And then aspiration acquired, it's just, I think you breathe in and it's in the air. Is that
close? Dr. Stanley, do you know? What was that?
Or like the droplets or something.
It's not necessarily in the air. So let me see. Dr. Stanley, do you know how you get an aspiration pneumonia? Or Stanny? Sorry. In group 11. Or let's go with Dr. Hannah Yerger.
Can you repeat the question, please?
How do you get a aspiration pneumonia?
I'm not sure. Aspiration, I don't.
It's okay. So does anybody know in the class?
Oh, is that an infection?
Uh-huh.
Like a lung infection?
It's a lung infection.
When you were inhaling and it gets into your, I can't think of what I'm trying to say.
It's okay. So she has dementia. She's usually by herself.
Oh, is it? I don't know what the medical term is, but like when you're drinking something and like you choke on water or something and it goes down the wrong side
Exactly.
and you get liquid in your lungs.
Exactly. So you eat something or you drink something and it goes into your lungs instead of your esophagus. So that's an aspiration event. And so when that happens, you introduce bacteria, usually from the mouth into the lungs, and that can cause a pretty bad infection. And so, does anybody in the class? You can just talk. You don't have to comment or anything like that. Anybody in the class know what the most common cause of death for anybody with dementia is?
Choking.
Close.
Or forgetting to eat.
Forgetting to breathe.
Nah, close. No. So we just mentioned it's aspiration pneumonia. So with an aspiration pneumonia, so Samer, a lot of times when your dementia progresses to the point that you are no longer able to control your airway, you actually aspirate onto things that you're eating or drinking, and that causes pneumonia. You can have recurrent pneumonias because of it. And so the most common cause of death for people with dementia is some type of pneumonia or some type of infection. All right, so I have like 2 more minutes before we have to switch to the next class. So for this patient, she had pneumonia. We treated her with antibiotics. Typically in the ER, we'll give ceftriaxone, and we'll try to, and we can also do azithromycin if we think that they are, it's community acquired. And we can go over antibiotics at a future date, but typically we make sure that they get better. And if they're getting better on those antibiotics, we send them home with oral antibiotics. And so for her, she got better pretty quickly and was sent home. So any questions about this case, any feedback, anything you guys want to say? DKA does cause confusion as well, but for this patient, she doesn't have DKA because her blood sugar isn't very high. Seizure can definitely cause some confusion, but with a seizure, you would typically have like they'd be lethargic almost immediately after, and they would usually have a shaking event that somebody would potentially see.
I have a question. This was actually just asked on the chat, but would we get an echo, and what would we see on the echo?
So I actually don't know why they actually got an echo for this patient. I think that they were maybe thinking pericarditis initially, but with the echocardiogram, if for pneumonia, you wouldn't really see anything. You can get an ultrasound of the lungs and you can see a pneumonia in the lungs, but for if you're thinking pericarditis, you would see a thickening of the pericardial sac, and it'll show you that you have pericarditis, and you can see a little bit of fluid between the heart and the pericardium. If you have tamponade, of course, you'll see a ton of fluid. So that's what you would typically see.
Another question, sorry. Troponin level of 0.07 here is not as like concerning, even though it's kind of on the higher level. What level would you be actually concerned with that number?
So that's a really good question. So the troponin being 0.07 is important because you don't know if that means that she's having an early heart attack or if that's just something because she's not perfusing her organs well. We know that her kidney was damaged probably because of low perfusion because of the sepsis. We know the troponin may be because of that too, and her heart is working harder, so giving her like something called demand ischemia. But what you would want to do is get the EKG, make sure that there was no ST segment elevation suppressions or T-wave inversions, and then you would also want to repeat the troponin. But overarching over all of that is her history. Does her history sound like a cardiac issue? And if it does, you're going to take that troponin super seriously. If it doesn't, then her cardiac history with the stents, but you don't focus on it. Does that make sense?
Yeah, it does. Thank you.
Yeah, it's that idea of pretest probability. How likely is this that this is the heart versus how likely is it's something else? Okay. There are a few more questions.
I kind of have a question regarding, like, how can we roll out the possibility that it was a pulmonary edema?
So pulmonary edema typically happens bilaterally. So pulmonary edema is usually because of heart failure, and so the pump is no longer working, so fluid backs up, but it's not going to back up into one lung specifically. It'll happen to both. So you'll see it more symmetrically.
So given her current PMH and her vitals and stuff, if we had seen, you know, both sides affected on the chest x-ray, could we still keep that possibility, or was it something else?
You would keep it a possibility, but then you can also look at her if she had any venous jugular distension, because that's a sign of heart failure. You'd have to look at the whole picture. You can also get an echo for that to see if there's any dilation of the ventricles. Yeah, does that make sense?
Yeah, thank you.
Yeah. So Meghana asked if pneumonia can lead to pericarditis. Not typically. Pericarditis is usually because of other viral infection that causes inflammation of the pericardial sac. The pleurisy is due to the pneumonia. It's not because of pericarditis. So pleurisy is basically the symptom of pain when you are deep breathing. So it's not a specific diagnosis. It's a symptom. Okay. Coronary artery disease. Yeah. Let me see. So her platelets are 450. So that's the higher level of normal. But that platelet level isn't really concerning. The platelets are actually a inflammatory marker. So whenever you have inflammation, you can also have an elevated platelet level. So the antibiotic I would give her is probably ceftriaxone and maybe azithromycin, depending on if I think it's a community acquired or not. And you always want to give an antibiotic that's more broad initially when you don't know what bacteria it is. But most likely this is a strep pneumo community acquired pneumonia, because that's what's most common. And so that typically responds to ceftriaxone really well. Why is it not a pleural effusion? So the pleural effusion, again, it's fluid builds up because of, or actually pleural effusion. So pleural effusion is how would I explain that? So it's pleural effusion, I guess, it's more of a inflammatory response to let me think of how I would explain that a little bit better to make it yeah. And I'll reply to you. I do have to go to the next class though. But if you guys have more questions, write them on the classroom and I'll answer them. So Saya actually replied really well. So it's a buildup of fluid between the tissues that line the lungs and the chest. So yes, but you can have that with a pneumonia as well. So that's why I'm trying to think of a good way of explaining it. But message your questions on the classroom. I'll go back and read through them and answer them. I hope that this was helpful and gave an idea of how it's going to go. Next time we do this, you're not going to know anything about the case, so you're going to be asking me as if I was the patient. All right?
Thank you.
No problem. Bye, guys.
Thank you. Thank you.
Thank you.